And coming, excuse me. Maybe I should have sang a little bit more in the beginning. And kind of coming to this conference, it really helps to kind of reaffirm the work that we're doing there. You know, I'm not a patient care kind of guy. I could never handle blood, so, you know, props to you. But that being said, you know, it's difficult because we aren't, you know, working with, you know, specific clinicians at the point of care. And so sometimes you could get stuck on a legal agreement. Sometimes you could get stuck in a project. And it's hard because you kind of come up these obstacles and you're like, well, you know, what are we doing this for? You know, we're making such small progress. You come to a conference like this, you get reinvigorated. And it's just, you know, last year it happened for me, this year it happened for me, and I'm really thankful to the MyHIN folks for putting this together. So that being said, a couple of things in regard to this presentation. This is very health system specific. You know, this is from the perspective of how we kind of view HIE, and you know, we're leveraging a number of different applications in partnership with Epic in terms of being able to offer health information exchange services to the provider. A few years ago, actually at this conference, somebody mentioned that you know, HIE really should be invisible to the provider. You know, I like my job, I do, but ultimately that's kind of what we're hoping for, right? You know, we want to be, you know, not in the background causing waves or annoying physicians or providers, but we want to be able to enable them with the kind of information that they need at the point of care. But not only that, you know, our quality department, our population health office, our you know, any kinds of you know, registry work that we do, we're very cognizant of that, and there's a ton of data and use cases that we can have for the data besides just point of care. And so we're, you know, we're broadening you know, the way that we're looking at this data and really trying to integrate it in useful and creative ways into our EHR Epic. And so, slide please. Oh, actually, maybe I could just grab this. Okay. Hopefully I don't break this too. So we're going to go over the Michigan Medicine HIE strategy. I think there's a really good reason for doing that. The main reason is because without the strategy, how do we go about implementing all of these different kind of HIE tools, right? You know, the landscape is changing so much. We have to have some kind of prioritization, some kind of focus, some kind of guiding principle to allow us to know what we're supposed to do with all of this. Then we're going to go you know, very practically into the current Epic tools and applications, and then the future Epic tools and applications, those things that we're really interested in. We've left a good amount of time for questions, and actually, you know, I don't know, and David, I didn't actually ask you about this before, I probably should have, but you know, as we're going through these separate applications, you know, if people have questions, are they able to kind of dialogue? Okay. Okay, great. You know, I'm more than happy to kind of take questions as we go along because these applications that we're doing are specific and they're used in kind of a myriad of ways. And so, you know, if you do have questions, feel free to kind of reach out. More than happy to do that. So questions throughout, and then also time for questions at the end. So this is our overall HIE strategic goal at Michigan Medicine. Now, I'll read it verbatim, and then we'll kind of go into some of the background. But enhance patient care and safety through sending, receiving, and consuming all clinical data on the Michigan Medicine patient population in the most efficient, effective, and seamless manner. So it's a lot of words. As you can imagine, I work at a large health system, and so a lot of people had input in it. But that being said, you know, I think it's an exhaustive, you know, statement in terms of what we're really trying to do. Enhance patient care and safety, of course, that's the #1 aim. You know, that's our burning platform, right? We know that these data are out there for our patients, and we need to be able to get it, especially acting oftentimes as like a tertiary and quaternary care provider. Right? These are complex patients oftentimes that are coming through our doors. And so we need that extra data from where they're getting care elsewhere in the state of Michigan. We something else that I want to kind of point out here is consuming all clinical data. You know, we left this particular part of the actual strategic goal completely open, right? You know, as of right now, it's other hospital system generated care. We're not really seeing the consumer data yet, but we know that's going to come. We know that it's going to hit us, and we're going to have to do something with it pretty soon. And there's going to be a lot of it, right? People have wearables, you know, monitors, things of that nature. That we're going to have to, you know, figure out what to do with that kind of information. And, you know, of course, the Michigan medicine patient population, kind of getting to that value-based care facet. You know, as you've heard in the last few days, we're moving from the fee-for-service to the value-based care world, you know, population health, accountable care organizations. How do we make sense of that? In terms of, or clinically integrated networks, you know? How do we make sense of all of this in the regard of, you know, sharing patient information? So these are kind of the principles of that overarching strategic goal. So we have 4 of them. We have data sharing, data acquisition, clinical workflow choice, incentives, and regulatory. And so data sharing is relatively straightforward. We want to focus and improve the work with HIE services that can transfer the most useful health information in the most efficient manner. So it's kind of getting to that, you know, the whole sharing of the information, right? Transfer the most useful health information. That's pertinent because there's a lot of information that's out there, and not all of it's useful, right? And so that's kind of how we're thinking about it. There's a priority, right, to the amount of data that we can send out. Data acquisition and clinical workflow choice are kind of 2 things along the same arc. Those are both kind of coming into our health system, right? And so data acquisition is to continue to acquire and integrate the data, which enables the clinical departments to access the outside information. So what does that mean? That's going to the whole consuming all data. We want all of the data to come in. We want to acquire it and integrate it, but it doesn't necessarily mean that we want to push it to the provider. As everyone's kind of been saying over the last few days, you know, we are going to get just a wave of information, and the last thing we want to do is to inundate our providers. So what do? We bring it in, but we curate it. We make the data available, which is number 3, to providers, with providers to integrate patient care data in the clinical workflow context. The word context was actually added by our chief medical officer because the physician context is really important, right? When you're doing your patient care, you really don't want to go into a separate window. You really don't want to be looking, you know, in a separate tab. You want to be able to look at kind of that longitudinal record, and that context is really important. And also aligning with Michigan medicine goals. As Dr. Tom mentioned, you know, we are doing a lot of affiliations within the state of Michigan, and so HIE is also critical to that particular facet of it. You know, work with clinically integrated networks, work with different you know, provider organizations and other hospital systems. And lastly, incentives and regulatory. You know, the space is crowded. We have payer incentives, we have federal incentives, we have state incentives. You know, we have to make sense of it all. You know, very simply, it's comply, but at the same time, you know, I manage a small team, and we have to kind of make sense of it, and also make sure that we're meeting all of these different incentives and regulatory goals. So these goals were actually, these goals and actually the overarching strategic goal was approved at the highest level of our organization in terms of IT by a committee that is chaired by our CIO, Dr. Andrew Rosenberg, and our Chief Operations Officer, Tony Denton, including a suite of other C-level folks. And so the great thing about this is also we have, we're fortunate enough to have a lot of support within our organization. And you know, I'm personally really grateful for that, and I think that, you know, we're kind of turning the tide to be able to understand, what the kind of clinical value is behind it. And when that happens, then you can start making some really cool stuff happen. And so we're going to get into some of that cool stuff that we do with Epic here in a second. So current Epic tools and applications. There are a few caveats here. The number one caveat is actually Michigan Medicine loves to brand. Actually, if you didn't know that, we actually changed our name from the University of Michigan Health System January 9th to Michigan Medicine. And so not only do we love to brand things, Michiganize things, if you will, we actually changed our Epic instance to be called MyChart. So if you hear me say MyChart, that's our instance of Epic. We've also branded other things like Epic CareLink to be the provider portal. And so I'll use these interchangeably. It can get confusing. I'm going to try my best to not be confusing, but we really enjoy branding things over there. All right, so starting off with Care Everywhere query. How many people are familiar with Care Everywhere here? Everyone, mostly? Okay. This is a great product in terms of us partnering with Epic. It's really the main kind of application product. And so we went live with it in early 2014, and it really helps us to connect with other organizations to pull their records. As the Cerner gentleman, Brent, was mentioning before, Care Everywhere has similar functionalities. We're able to reconcile meds, med allergies, problem summary lists, and immunizations. In particular, to a question about talking about how to actually do immunization registry work, we're actually working with the state of Michigan to do that bidirectional MICR query for immunizations. And the great thing about reconciling it is that within the provider workflow, you're able to select and mark which ones you want pulled into the chart. And so that's one of the things that our providers really enjoy, is being able to pull in those discrete data elements that are coming in from the CCD. So Care Everywhere Direct Messaging. A lot of people have been talking about direct messaging. We connected our Epic instance with the Great Lakes Health Connect Medicity HISP in 2014. And so we chose that. We've been a long-time partner of Great Lakes Health Connect, and we decided to do so for a number of reasons. And it's been a great kind of relationship. But still, in that, you're integrating that into Epic in order to send and receive those CCDs. So the individual direct addresses were created, in our Epic instance for each provider, along with, we created 22 departmental direct addresses. So in terms of the hard thing too with HIE, and especially for us, is that the scope of HIE is so big, right? I mentioned affiliation work, I mentioned point of care, I mentioned quality. But not only that, we use these 22 departmental direct addresses for referrals. And so we actually, two really big referring groups are actually asking us, hey, we really enjoy doing the referrals, the electronic referrals with you. How can we go live with direct message only referrals in the next 3 months? And fortunately enough, Epic has put together fantastic workflows for us to be able to handle that. And so we're in the process of being able to move really from that kind of fax life that everyone does for referrals and move into the electronic world pretty seamlessly, which is fantastic from our perspective. There are growing pains, of course, but we have this great workflow in terms of all of the direct messages are able to come in and hit one list for our health information management department. They then do some of the manual patient matching, and we're also, Epic has some automated patient matching as well, but we leverage that, and it just matches basically that incoming CCD to that patient's chart. And so the providers are able to go into the patient context, that particular patient, be able to get that CCD. It's fantastic. And then from there, if there are actual referrals, they actually basically flag them. They flag them. It goes to MLine. for any other provider groups present, you're probably familiar with MLine. That's really kind of like our outside sort of physician liaison kind of referral pool area. And so whenever somebody has a referral, something that they really need to get somebody into Michigan, they actually contact, call, fax, communicate with MLine. And so it's able to be built into existing workflows that we have. We were very happy about when we were setting this process up. And then so MLine is able to take those messages that are referrals, able to transcribe them and basically put them right into the queues for each individual clinic. And so our individual clinics are able to refer internally. They use a specific queue. And then we actually are able to take those direct message referrals and put them into those same very queues. So the people, in terms of registration, scheduling, are just working off just one queue. And it's seamless to them. We would hope sometimes that they would probably read some of the fine print so that they could know that it's coming from an outside entity. But that being said, they don't know the difference between an internal versus an external and are able to schedule accordingly. And we've seen some great success in that regard. The numbers, well, actually, let me get to the last one is the ED project. So I'm glad that we put that point in there. Otherwise, I would have forgotten it. As of yesterday, we actually just started a project, or we went live rather. It's a project where everyone, I'm sure, is familiar with the CVS Minute Clinics. If a patient shows up to a CVS Minute Clinic and the condition or whatever they come and present with happens to be emergent, CVS is actually able to send us a direct message and transfer that patient to our ED. And so this kind of new emerging workflow of leveraging direct messages to be able to work with these kind of outside entities, being able to transfer in real time, that's unbelievable, right? The patient shows up, just came from CVS. We have the information there, waiting for the ED clerks, and they're looking at the queue, seeing who's coming, and they know and can prepare accordingly. And so it's a fantastic project that we went live with literally yesterday. So I think it's great when we're being able to make those inroads with kind of unique projects. So in 2016, we processed over 37,000 direct messages from over 150 organizations. Our HIM department is a little bit busy now with those, and it's probably gonna increase. But at least, hey, they're not getting paper cuts, right? That was a joke. Care Everywhere auto query. So this is a neat functionality. I'm going to actually get a quick water. We went live with this functionality in 2015. It's a neat piece of functionality, and in the simplest terms possible, it's configured to query other organizations who are near a patient's listed home and work address. And so 3 days before an encounter, it'll automatically query to pull records from other Epic organizations. So let me take you through kind of a use case or scenario. John Doe, says that he needs to kind of come in for whatever reason. The patient is scheduled. We take a look at basically wherever he's from versus, address versus work. And then 3 days before, there's a batch that kind of goes out, a little bat signal, if you will, for information from other Epic organizations. And by the time that patient shows up, the information is there. It's waiting for him in terms of being able to understand what kind of work that he's gotten at other Epic organizations. This is a fantastic functionality, and we really enjoy it. And significant improvement in the actual matches. So, the base Care Everywhere query functionality is manual. In 2 to 3 months, we surpassed those numbers that we already had when we went live, a year previous by turning on auto query. And so it's a great functionality for being able to receive all of the information from those other institutions that are on Epic. So just going through some of the numbers, they're pretty staggering, we've been able to exchange patient records with organizations in all 50 states. It took us, there was a weird thing with New Mexico, I think, for a little bit, where they were just kind of the outlier. They were like we were at 49, and I was kind of looking at the report, and I was like, got to get somebody up from New Mexico to just, fill that gap. But all 50 states in 2017, so this year, 1.4 million, patient records exchanged, 5.4 in 2016. And if you do a little bit of the math, you're actually kind of realizing that year over year since we went live, the amount of patient records exchanged is going up significantly. So we're seeing really, really great results as the network kind of increases and the data and the breadth gets wider. So 9.6 million since our go live in 2014. We've exchanged patient records with 1,120 hospitals, 1,380 emergency departments, and 31,840 clinics. So the numbers are there, These are palpable numbers that are demonstrating value to our organization. The Michigan Epic community, you'll have to kind of correct me, Jeremy. There are 12 Epic organizations now in the state of Michigan. Sorry to put you on the spot like that. I think there are 12. Mid-Michigan went live April 1st. And so, the numbers are accordingly, much larger. You can read them for yourselves, but 52 million total records exchanged. And so it's a staggering number. We've all kind of gone live at different times, and everyone is now on Care Everywhere. And now that everyone who is an Epic shop that is on Care Everywhere, we're able to see some really great results in terms of being able to share those kind of records. So specifically, talking about clinical value, people were mentioning Julia Adler-Milstein. She's a University of Michigan School of Public Health and School of Information professor. I've had the pleasure of actually working with her on specific research studies. And so this particular one was published in JAMIA in 2016 in regard to looking particularly at Michigan Medicine's emergency department. So what we did was we helped compare the facts to the HIE, if the results came in, the two different outcomes. And the numbers similarly here kind of speak for themselves. Getting outside records 1 hour faster via Care Everywhere versus fax meant for our emergency department a 53-minute shorter visit time, 2.4 lower likelihood of admission, 2% lower likelihood of imaging tests, and 1,187 lower average charges. So the actual numbers, again, they really speak for themselves in terms of the value that we're getting from leveraging Care Everywhere. So the next application that I want to talk about, it's another Epic application, is something called Epic CareLink. And we went live with this in 2014. 2014 was a busy year, as is most years, but 2014 apparently we went live with everything. Because we had a need for these external users to be moved off of CareWeb. So CareWeb was our homegrown EHR. And so what we did, pre kind of meaningful use and going live with Epic is that we were kind of under this practice where we would allow close kind of community providers to have access to our homegrown EHR. For those of you who are, either from HIM or compliance or legal, you might be, kind of scared right now, because for good reason. It was actually a terrible business practice, but we realized that it was kind of an issue. Of course, we really did have other gateways in place and stuff like that, but in concept, it's not a generally good business practice. So we realized a really big need for that. Not only that, but also there's a really big external referring network that we also had to address in addition to that. And so we needed to restrict data access in kind of meaningful and pointed ways for these external providers. And so we went live with Epic CareLink in order to restrict that unfettered data access. What it is, it's a read-only web-based view of the Michigan Medicine Epic Instance MyChart. Again, we branded it as the provider portal, so that's maybe how you guys know about it or have heard of it through one of our physician liaisons. We've seen the numbers and the demand for it increase over time in regard to not only external providers who are interested in getting our information, but we also are able to leverage it for very specific access requests. So research users, insurance auditors, we're able to give them specific patient lists for a certain amount of time to access those patient records. And so, they just have a web-based view of it. They log in with their credentials, get access to the data that they need, and then, everyone kind of goes on with their lives because they're kind of kicked out after a certain amount of time. And so it's a great use for those specific kinds of use cases. This is somewhat of a nondescript kind of upward graph, but it says up there on the left-hand side for you all, logins per month. And so we've seen an increase over time, like I said, of people who are kind of using the portal. 13 different kinds of user types, so we're able to kind of configure it to our needs. 13 might seem a lot. It's because we have a lot of very specific needs. 3,700 plus users, 1,100 plus unique sites. And so there are a lot of people who are using the portal. I know that we're trying to move off of portals. That's kind of one of the things that we talk about here. I think that there's a specific purpose for this particular application, in different ways that people are using it. And we'll see them kind of probably linger around for a little bit longer. And it's not for a bad reason, because people are using them. So GLHC functionality built into Epic. We've been a long time GLHC partner. Started with them in 2011 when they were Great Lakes Health Information Exchange. And we were trying to find out a really good way to integrate their data into our EHR, Epic. And the way that we've decided to do it is that actually we built a single sign-on link that's embedded within our Epic instance. So if you just kind of follow that workflow, they're in the actual patient context. They're in, so-and-so's record who happens to have gotten care at some of these other kind of non-Epic facilities, and you're able to just go from their patient chart, other clinical systems, Great Lakes Health Connect outside records, and you're able to request the Great Lakes Health Connect records. It launches a view of Viper. For those of you who aren't familiar with Viper, that's their longitudinal web-based health record. And our providers are then able to kind of see all of the data that's out there in Great Lakes Health Connect for that particular patient. And so we've gotten a ton of value from it, and it demonstrates some of that flexibility that we're able to build within Epic to be able to create new buttons, to be able to build these single sign-on functionalities to access some of these kind of other data repositories. Again, another graph of just upward sloping, but this really demonstrates we went live in February of 2016, so it was somewhat relatively recent. And as of 2017, we're getting 9,000 queries per month or clicks into this. And granted, it's not elegant. I think that you guys could all see that. It's not the most elegant thing to access Viper. They still have to kind of go into these different buttons to be able to access it and click. But people are getting value out of it. If they're willing to kind of go a little bit outside of their clinical workflow to do this, that means that they're getting value from it. And actually, as of last month, we had 11,500 queries thereabouts. And so the numbers are going up significantly, almost 1,000 queries per month through Great Lakes Health Connect. And so we're finding different ways to practically and easily integrate data from these different data sources for our providers to equip them really at that kind of point of care. This is just a random kind of data schema. It shows actually how we're mapping our ADT. And so it does kind of demonstrate the complexity of it. But in order to land and do something meaningful with the MyHIN data, in particular, this is the ADT data, we're actually taking the data and we're landing it in something that we have yet to come up with a better name. Actually, if you guys have a better name for it, that'd be great. Our outside records database. I should probably put in a trademark for that right now before you all do that. But that being said, you know, it's complex. There's a ton of data. ADT is really good data in regard to patients showing up in other organizations. And so we're trying to take these data and store them and land them in a place so that we can actually start building it into Epic workflows. And so we're taking it, we're parsing it, and then we're actually building reports off of it by storing it in our health system data warehouse and other kind of data stores that we have. And so this is just a kind of generic view of some of the reports that we actually have created off of that ADT data for our 29 care navigators. The care navigators as part of my PICT, the Michigan Primary Care Transformation Project. And so, this list is kind of what our care navigators work through on a daily basis. And kind of the fourth one down, the external previous day discharges. That's the ADT MyHIN data that we have that's stored. We built a report. It looks and feels exactly like the other data that's already sitting in Epic. And so our care navigators are able to kind of pull up a report based off of the clinic that they're working in and call up each patient to say, hey, look, you got discharged from this place in Alpena. You had this diagnosis, you had these kind of perhaps chief complaints, what's going on, how can we help, things like that. And they do that not only for internal U of M discharges, but also these external ones now. And the care navigators are seeing results from following up with these patients. And so this is just one of the ways that we're able to leverage the flexibility and storing of the data and being able to create reports in their kind of workflow, in the care navigator's workflow, in leveraging Epic. So future Epic tools and applications. I do want to leave a good amount of time for questions. I'll go through these probably pretty quickly. What we were or what's been talked about a lot is, in kind of short, trying to not, create extra work for the provider. I mean, that's the last thing that we want to do. This looks, quite frankly, like a lot of work, right? We have multiple HIE applications, and the location of the data is in different parts of the chart, and it's because we have different data sources and things of that nature. You have different tabs, you have different ways that data are getting in from various pieces of information. And so what we'd really like to address and kind of work on is to be able to come up with a single view of the patient data. Few locations for the outside records in the chart would be ideal. I think that's pretty straightforward. Well, Epic is working on a fantastic project that we're really excited about called Happy Together. And what this is it's a design philosophy. It's not really even an application. It's a design philosophy in which that they create views of patient data from both of the internal and external data sources. And so it's located right within the patient chart. And so let's say, for example, encounters, right? You go to the encounters tab, you see what other encounters there are for a particular patient at Michigan, and then you're also able to see that they had these outside encounters and where the encounters came from. And so we're extremely excited about this functionality, and it leverages a lot of the data from Care Everywhere. And so not only are we excited about that, because no longer will providers have to go into an area for Care Everywhere and outside data, it'll be built right into their views, so much so that we're trying to really consider how to expand that data set, leverage the Great Lakes Health Connect data that we have access to, leverage the MyHIN data that we have access to, and be able to build really all of those views into kind of one area for the clinician. Yep.
I'm going to do what you said earlier. I'm going to ask questions as we go on.
Please.
So you have that internal and external data. You're able to present it to the provider and all. Is there a way to reconcile that, to pull it into the chart if they're
Yes.
a simple way? Okay.
Absolutely, absolutely, yeah. For 4 specific data elements, we're able to actually pull in meds, med allergies, problem summary lists, and immunizations. And so, similar to the Cerner kind of functionality, we're able to pull in some of those discrete data elements. Thank you for the question.
Yeah.
So care equality, Dave Castle spoke 2 days ago. He's the director of care equality. And so we are in the process of implementing care equality. This is something that we think that will fill a gap. Oftentimes there are sometimes borders around, like geographic borders in terms of specific data. And we are hopeful that we'll be able to get a lot of the kind of non-epic, outside of the state kind of data through this way. We're really excited about care equality too. It's built into the workflow of Care Everywhere. And if you remember that kind of auto query functionality, it'll really allow for us to be able to query, auto query for these CCDAs from other, places outside of the state of Michigan, and also kind of smaller EHR vendors that we haven't been able to kind of get data from as easily. Think of like Athena, think of eClinicalWorks. And then lastly, the last feature functionality that we're doing is leveraging care equality in addition with SureScripts. So SureScripts National Record Locator Service. If you aren't familiar with it, they have a new service in which it basically leverages the prescription information to determine where patients have been seen before. And so it's able to kind of cast a wide net. And if those people also happen to be on care equality, we can pull CCDs for those particular patients. And so it addresses the issues with finding where patients have gotten care. Oftentimes, people are kind of transitory in kind of that college, university setting. And so, we need to be able to track those patients over kind of large swaths of area. And so this too is built into the workflow of Care Everywhere. So I was given the time warning of 15 minutes left, and I actually wanted to leave 15 minutes for questions, and we can actually kind of probably go back and forth also if you had questions about specific applications.
Good job, great presentation. I had a question. Are you seeing any changing views now with the pull technologies where people are relying less on the push technologies? And I mean, you have a lot of different ways of getting data. I don't think
Right.
we never seem to have people saying, I can't get the data now, but
Right.
now we're hearing, sometimes I'm getting too much stuff pushed at me. So I was just curious what your experience has been with pull versus push technologies.
Sure, absolutely. Well, I think the difficult thing about pull versus push is that push, there aren't, and we haven't done this, Epic has the functionality of being able to alert when there are new records that are kind of being pushed, and you could send them straight to an in-basket. We're not doing that because our providers actually, I think, would get pretty annoyed at us. But that being said, the push is difficult in the regard of, they're not being alerted that there's something out there for them to kind of go look at. And so there's difficulties in that kind of data push. In the pull, if they're doing like a manual query, then they're doing it, and so they're looking at the data. Auto query kind of turns that pull into a push. And so it really depends on the kind of workflow, and we're a bit decentralized at Michigan. And so it depends on kind of clinic workflow. And actually, as of right now, something that we're doing is we're kind of piloting actually a survey. We have a lot of data on what people are doing. So are they looking at records? Yes or no, we have percentages on that. Are they clicking the button? Who's doing it? Stuff like that. But we're not really getting to like the why, right? The why of well, do they not like the functionality? Do they not like, having to go press these other buttons, And so we're trying to do a survey of kind of figuring out the why of it. And I think that hopefully we'll be able to address some of those things like the pull versus the push, and kind of the kind of clinical value that they're perceiving, that they're receiving from these different HIE services.
For your referral process that you were mentioning, where all the referrals are coming into your M-Line direct address queue, are you responding to those senders via direct as well? So acknowledging their referral and letting them know that it's complete or needs more information?
So we're not via direct. And there are a couple of reasons for it. It depends on the sending direct message, right? It's extremely variable. So it could be coming from a centralized referral area, which may or may not ever get back to the provider. It could be coming from small doc areas. So what we've done is, we have all of the provider information kind of linked in the background. And so we've set up a way to send faxes back to kind of close the loop. Michigan has kind of a bad reputation sometimes of being a little bit of a black box. You refer and then you never get anything back, and apparently the patient has been seen like 1,000 times. Well, we're trying to limit that, we're receptive to that. We realize that it's an issue. And so we're sending back faxes. M-Line also helps to kind of close that loop as well. And so we're trying to make steps or take steps. And eventually, I think, we would love to do kind of the direct message kind of send back, as long as also I think, the workflows have to be there and a little bit more standardized in terms of the direct messaging kind of capabilities.
Thank you for your comments. It's been very informative. We've been hearing over the last couple of days, and even in the prior presentation, about really the patient owning their data. And we talked, gave very good examples of how you're communicating with providers and integrating provider data. Do you have strategy for working with PHRs, or how do you see that working into your strategy?
Sure, absolutely. So this is when I reference you to art. No, I'm just joking. I was actually saying that. So Tony works in our ambulatory, functionality, and he's here and he works on the PHR. The thing that's kind of interesting actually is within the scope of HIE at Michigan, PHRs don't yet kind of count within that realm. And it's kind of an interesting thought because we've debated actually a number of times whether or not PHRs do kind of count as HIE, whether or not they don't. And so we're actually kind of putting a little bit more of a focus on it because there are also OCR kind of requirements that have been coming out recently about kind of doing that. And so, our view of the world in terms of PHR and working with them is rapidly changing. That's the best way that I can kind of answer it, because it's actually not really kind of in this presentation or other presentations that I've done, because of the fact that it's not HIE. I'm focused on connecting with kind of other providers, and that's really kind of been the scope and the focus. You're fine. Go.
Okay, thank you. When you have data coming from multiple sources, how do you handle which one is your priority, which one you actually present?
Sure. Yeah, absolutely. As of right now, the data sources that are coming in from multiple areas, we don't yet have a way to prioritize that particular data. So it can get a little bit confusing at times, and we're working on ways. Something that's inherent actually within Happy Together, another reason why we're excited about it, is that there's deduplication functionality within it. And so we're hopeful that we could leverage that by kind of turning on the cipher, in that regard, and allow for some of that deduping kind of functionality to happen. Also with MyHIN's common key, that we're implementing very soon, that too can help in terms of being able to kind of create a very seamless view of the actual patient record.
So I'm wondering, you mentioned that as consumers become a bigger part of your HIE strategy, that you expect this to change, and you mentioned that researchers can access the the provider portal to do some limited patient list kind of based
Correct.
research access. And one thing we've talked about in the consumer space at MyHIN is how can consumer-mediated health exchange really impact data donation or more advanced research. And being, our best research neighbors, we're curious what does that look like? Have you guys had conversations about that? I know internal researchers have access to the EHR, but
Right.
what have you guys thought about for external or partner consortium kind of things?
So there are a lot of kind of thorns in terms of external research. In particular, the thing that comes up the most often is how we handle IRB review. And so I think we're still really trying to wrap our minds around it. That there maybe could be a way that you could actually have a combined kind of IRB, but as of right now, how do you actually go to the other organization and say, hey, look, we have to get this pushed through your IRB and IRB and our IRB? How does that kind of look and feel? And we really haven't been able to get past some of that. Also, in a lot of the legal agreements that we do currently have, is for payment operations and that purpose only, right? For healthcare purposes only. And so we've been getting a little bit more progressive in terms of including kind of the word research in some of our legal agreements, but yet we haven't yet kind of gotten further in terms of specific use cases for research. We're very interested in it though, of course.
Thank you.
One or two more. Yeah, any other questions out there? Helen.
Thanks. I was wondering if you're doing anything with clinical trials through HIE. I get questions periodically from groups across the country.
Sure. Well, so similarly, we're not. And actually, we maintain a list of restricted departments. And actually, all of the clinical trials departments that are doing specific research, we actually have to block. Because, for double-blind studies, things of that nature, we can't disclose certain pieces of information. So unfortunately, that's something that's, within the research realm that we haven't really been able to kind of expand, the uses yet into for HIE.
Great. Well, thank you, Jeff. Appreciate it.
Thank you.